Good afternoon, and welcome to our multimodality imaging series. I'm Mike Quinones, and we're going to have a two-part series on cardiomyopathy. So today, I'm going to start a discussion on the role of echocardiography in cardiomyopathies, which is obviously a very important role. And then I'll be followed by Dr. Dipan Shah, who is going to start the part of using CMR for the evaluation of myocarditis and dilated cardiomyopathies. Then the second part of the series will be Dr. Shah and Dr. Almala discussing more of the use of CMR for infiltrative diseases and inflammatory diseases. So with that intro, let's get going into echo, because echo usually is the very first tool that we use in cardiomyopathies. So when I talk to my patients that have a cardiomyopathy, I tell them we're using a very fancy word to simply say that you have a disease of your heart muscle, because that's really all that cardiomyopathy means. And as you know, patients can present in many forms. They can present with a very severe acute heart failure, like in a myocarditis, in a more subacute subtle way, with symptoms over 2 or 3 months, developing heart failure, or even chronic. Sometimes patients come in with long-standing symptoms of fatigue and some shortness of breath. They thought they were deconditioned, and then they're discovered to have a cardiomyopathy. They can present with arrhythmia, ventricular arrhythmia, sudden cardiac death, HRV, and even SVTs. And even asymptomatic patients, I had one last week, presents complete asymptomatic with an abnormal EKG. So that is not that much of an uncommon presentation. And then, of course, you have the patients that are family members of patients with cardiomyopathy that may get screened at a time in their life when they're still asymptomatic and are found to have the disease. So there are multiple presentations of cardiomyopathies. If you go through the billing part of codes, this is one of 3 pages. So the folks doing codes for billing have really done their homework. And believe me, nobody could remember this. But just to give you a few examples, they have here the diabetic cardiomyopathy of diabetes, the Duchenne's disease, cardiomyopathy in the perpetuum. You name it, toxic cardiomyopathies, and so on. So there's a lot more codes than we care to remember. So when we talk about how do we classify cardiomyopathy, obviously we want to simplify it. One simple way is to simply look at the heart itself. Is this a dilated cardiomyopathy? Usually the LV is enlarged and they have some reduction in function. Is this a hypertrophic type, or is this more of an infiltrative kind of cardiomyopathy? And then we have this package of others that don't fall into any one of these categories. Another way of looking at it is some of the structural functional changes. The ones in red are usually coronary artery disease, and we're not going to discuss CAD in these lectures because we have plenty of other times that we have discussed it. But obviously there is an ischemic cardiomyopathy, which is LV dysfunction due to coronary artery disease. But even scar and ischemia, which are shown here in red, can happen with non-ischemic cardiomyopathy due through other mechanisms. So from a structural point of view, you have the presence of scars. You also have inflammation, like in sarcoid. You have vasculitis effects, like in lupus, infiltrative diseases. From a functional side point of view, you have the cardiotoxic cardiomyopathies with all kinds of different agents that can be toxic. Sepsis, endocrine disorders, diabetes, even high cardiac output states. And then you have all of these genetic mutations that can produce a cardiomyopathy. And of course, often we are left with unknown causes. Viruses obviously can be one of them. We talk about alcoholic cardiomyopathy, alcohol being in some patients cardiotoxic. But it's not uncommon that we have a dilated ventricle, that we have done a full workup, and we still don't know. And that's when we use another fancy word that we use is idiopathic, which I tell my patients it's a fancy word that says we have no idea. So that's the bottom line with cardiomyopathies. But no matter which cardiomyopathy you have, the earlier diagnosis can be done, the better we have opportunities to intervene prevent or reduce heart failure symptoms and outcomes and improve the overall survival for patients. So the role of echocardiography really is in the forefront, that early detection, because usually echo is the very first test that somebody has after an EKG, and then something comes up as a finding in the echo that suggests there's a cardiomyopathy, and then the role of echo is early diagnosis and detection, look at structural and functional changes, right? That's where we have the diastology part, looking at cardiac output, looking at feeding pressures, pulmonary pressures, and so on. Structural changes, how big is the LV, how much hypertrophy, ejection fraction, strain, which we discussed previously. And then importantly, once you have that evaluation between the clinical part and the echo findings, is go to the next stage. What else is needed? In some patients, we might need to go straight to a coronary angiogram first. You have the role of CMR that you're going to be hearing a lot about that. Pyrophosphate scan when we're looking for amyloidosis, PET scanning for certain infiltrative diseases, and so on. Myocardial biopsy, genetic testing, blood tests like, for example, ferritin. So combining the clinical symptoms presentation with the echo then allows you to go to the next step, and quite often, a next step is needed. It's rare that you can stop just with the echo and do nothing else. So when we talk about dilated cardiomyopathies, most of them look alike. You have a big heart and you have a low EF. And you have a whole list of things that could be causing that finding. So that's where the need for trying to get a clinical history that helps, and then sometimes a little bit of other things like some blood tests. So here we have a non-ischemic on your left and an ischemic on the right. Well, probably ischemic. So why do we think probably ischemic? Because you see a very thin inferior wall that is akinetic or dyskinetic, and then this part here is hypokinetic in an enlarged heart. So until proven otherwise, this is coronary artery disease with probably a previous inferior infarction. However, there are some non-ischemic cardiomyopathies that can also have regional wall motion abnormalities. Now, if this patient has non-CAD or a good history of an MI, you put the two together, and I think the chances then are extremely high that you're dealing with an ischemic cardiomyopathy. So again, even wall motion abnormalities, although they point out to CAD quite often, occasionally can be seen in other diseases. Likewise, the one that we're calling non-ischemic, it's likely to be non-ischemic, but it could also be, as Dr. Zogby showed earlier, a coronary artery disease patient with stoning, could be a left main, for example, showing a reduced function, but viable myocardium. So a lot of these, when you have an echo in front of you that you're evaluating, really the clinical presentation is extremely helpful. EKG findings, all of that can help you point out in a direction as to where you should go next. And quite often, one of the very first tests that we go for is proving or disproving that the patient has significant obstructive coronary artery disease. And today, of course, we can do that with coronary CTA without having to always do an invasive coronary angiogram. Another heart that looks enlarged and reduced function. Could be many things, right? Could be a patient with a chronic history of alcohol abuse. It turns out to be a young woman that recently had a baby. Well, now that puts it very likely into a postpartum or peripartum cardiomyopathy. Nothing in this echo would be telling us that that's what it is, right? What about this one? This is really bad, right? You have biventricular enlargement and really bad function on both ventricles and biatrial enlargement. This is a very, very sick heart. What is it? Could be a lot of things. Could be a lot of things. But there's a very high serum ferritin. That now points out in one important direction, hemochromatosis. And in fact, it's not a bad idea as a clinician in any new patient coming in with a dilated cardiomyopathy finding to throw in a ferritin. It's very cheap, doesn't cost much, and you might discover early a diagnosis. We're going to hear later the role of CMR in hemochromatosis, but a simple ferritin examination in a patient presenting with a dilated ventricle and low EF can start the truck rolling nicely. So hemochromatosis, of course, has no distinct echo features, and the diagnosis is made by knowing that the patient already has hemochromatosis, doing a ferritin, and then, of course, you can follow through with CMR and other tests as needed. Now, this is one type of dilated cardiomyopathy that the appearance can point out to an etiology. And of course, this is left ventricular non-compaction, another disease where you tend to have a dilated ventricle. You have a range of ejection fractions. They can be very low, but they can also be just mild to moderate depressed. But the important feature is the smart trabeculation that the ventricle has, because it's an extensive spongy transformation of the myocardium, kind of resembling the fetal myocardium. So these coarse trabeculations and deep recesses are covering the endocardium. And the trick there is to look at these recesses and trabeculations, and then you measure the length of them relative to the thickness of the wall prior to it, and you want to have a very high ratio of these lengths to the thickness, what they call Y2X in this particular publication. Most of the time, it's an easy diagnosis to make. There are two sides of the story. One sometimes may not be as apparent and could be missed. Contrast echo can help at times. And there are other times when we may overdiagnose. You have a ventricle that is dilated, you have a little bit of additional trabeculations in the apex, and the reader throws in the diagnosis. So it's not always something like this, which came out, obviously, this is very, very apparent. So there are situations where you may either overdiagnose it or even underdiagnose it. And again, you'll hear a little bit later from Dr. Shah the role of CMR that can be very helpful in confirming or better establishing the diagnosis. When you have a very nice quality image and you see this level of trabeculation and recesses, it's a slam dunk. You might use CMR for other things, but at this point in time, you do have a diagnosis. Now, you have this group of patients, we see a lot of them, presenting with HFpEF, or what we call now HFmeth, which is ejection fraction in that sort of 40 to 50% range. And there's a lot of them. And many of them are just good old HFpEF with hypertension, diabetes, and so on. But they can also be other cardiomyopathies. And that's where we have the hypertrophic and we have the infiltrative cardiomyopathy, with amyloid and sarcoid being two of the important ones. So a couple of words about hypertrophic cardiomyopathy. We probably will cover this in more depth later. But it's a disease that is genetic. You have hypertrophy, usually asymmetric septal hypertrophy, but there are other forms. We'll see them in a minute. And you may have this systolic anterior motion of the mitral valve that produces the dynamic obstruction so well known to many people. And a so-called hyperdynamic heart that has a supernormal ejection fraction, although not always. They may just simply have a normal EF. Interestingly, many of them have reduced strain, global strain, despite having such a good EF. And what we see here is that, of course, you don't always have to have SAM, and this is an example of somebody that at rest has no SAM and no obstruction, but with provocation, which can be either exercise or Valsalva, you get the SAM and you get the murmur and you get the gradient, and many of you already know a lot about that because we have a very active service taking care of these patients. The important thing to remember is that the presence and severity of the dynamic obstruction has nothing to do with the LVH. You may have somebody that has just a tiny little bit of asymmetric septal hypertrophy, maybe a septum of 1.3 cms, and a lot of SAM. You may have others that have severe LVH and they have absolutely no obstruction. So there is no relation to the hypertrophy. And the current thought is that the factors that promote SAM the most have to do with the mitral valve anatomy and physiology. So patients frequently have an anterior displacement of the papillary muscles, and then they have elongation of the leaflets, particularly the posterior leaflet, and restriction of motion, and then frequently this geometric shape of the ventricle that combined with the hyperdynamic contraction drives the mitral valve forward towards the septum. And here are all the other forms. So asymmetric septal hypertrophy, 90%, but then you have concentric hypertrophy, apical hypertrophy, even mid-ventricular hypertrophy, and very rare asymmetric free wall hypertrophy. So basically, there are different forms of hypertrophy, and the key finding when you are looking at a patient is that the hypertrophy does not have a good explanation. So you have someone that has hypertrophy, but they don't have aortic stenosis, they don't have hypertension, except that they can also have hypertension. In fact, once you get into the adult group of patients, I'm following several apical HCMs that they're also hypertensive. So the lack of hypertension is actually not as great a criteria as you would want, because patients, as they get older, particularly closer to middle age and so on, they can have hypertension. For some reason, in my own practice, I have seen it more with the apicals than with the septal, but I don't know that that's a factual thing. Now, here we have, down here, the apical HCM, very classic, a lot of hypertrophy towards the apex, obliteration of the apex. If you do an LV angio, you have this very classic spaced ace of spades shape with a little apical, discrete apical cavity that can become akinetic or dyskinetic from scarring and fibrosis. They have a classic EKG with deep T-wave inversion, so the EKG often is the very first thing that makes you suspect it. And the important lesson and take-home message for you to take here today is that a regular transthoracic echo not uncommonly misses apical HCM. And I have seen patients that have come to us with previous echoes done by other people and they have missed it. And the reason is that a lot of the muscle in the apex can create an attenuation factor where you don't really see so well. Here, you potentially might be suspecting it, but really this doesn't come and hit you in the eye. So what are the tricks to try to reduce that probability of missing it? And this is for the sonographers in the group. Number one, always do a short axis at the apex. When you're doing your short axes, tilt that transducer way into the apex, because there is a very good chance that you will then see all of this hypertrophy here with a cavity that basically disappears during systole. That's number one trick. Number two, color flow can be very helpful, because with color flow, again, you can see then the obstruction here, and that will make you immediately be suspicious of apical HCM. And then finally, contrast really turns the lights on. And actually, a contrast echo, well done, looks just as good as a cardiac MRI. You can see very nicely the hypertrophy, you can see the apical trapping, and you can even see a little bit of dyskinesis right at the tip of that apex. So truly, if you follow these rules, you should very rarely miss an apical HCM. And then finally, quite often the strain will show a pattern of scarring with very low values in the apex, which reflects what's happening at the apex. And as you will see later with CMR, then we can frequently see scarring in that apical segment. Now, there are other things that can have a phenotype that looks like HCM. An athlete heart, although that usually is not much of a problem because they have excellent normal strain and they have totally normal diastolic function. Amyloids can, because they have that resemblance of hypertrophy. But again, there are other things that we will show later that should not be a problem. But then you have this very rare group of diseases, genetic diseases, where Fabry's disease is one that is important because there is a potential for treatment. And you can see that the echo, this is a known patient with Fabry disease, that could look like an HCM patient. The F is pretty good. They have this massive hypertrophy of the septum, so they could look like an HCM. So basically, it's a lysosomal storage disorder, accumulation of globotriaosylceramide, a lot easier to say GB3. Inside the cells, it's a toxic inflammation, and that leads to the heart phenotype. It's diagnosed easily with a blood test. There is a cardiomyopathy, frequently with hypertrophy. They also have conduction system dysfunction and a 20% incidence of cardiac death. So it's an important disease to discover because there's also now treatment with replacement of the enzyme and enzyme enhancement therapy. And they can treat the disease, ameliorate the symptoms, and obviously improve survival. The good news is that patients also frequently have this type of skin manifestation. So again, it's another example of taking an echo picture, okay, and putting it together with clinical findings to lead you towards suspecting a disease. And that's a story that you will hear repeated many, many times. All right, so we talk now about the infiltrative diseases, amyloidosis and sarcoid. And right here, another important slide to show, I think Dipan also likes to show this slide at times, is that when you look at 10-year survival, patients with dilated cardiomyopathy, obviously they have their own course of dying, but you can get close to 60-70% of them still around at 10 years. You look at the other disease, the infiltrative diseases, practically very few people are left for 10 years. And for example, hemochromatosis and amyloid, you don't even get to 5 years. So these are diseases that are extremely lethal. And the good news is that there are therapies, important even for amyloidosis, there are therapies now that can alter that course. So early detection is very important. So again, early detection is important, clinical suspicion is essential, and although the echo is abnormal, typical features are not always there. They're often lacking, so you really have to have this suspicion in your mind so that you can continue to look further. Biopsies obviously establish diagnosis, but that's not that frequently done, and their sensitivity is limited. And of course, you're going to hear a lot about how CMR can help. So this is a patient with amyloidosis. Again, what do you see? You see hypertrophic heart with a good EF. This could be some other forms of hypertrophy, maybe the Fabry disease. But you have, typically, you have increased wall thickness. The QRS doesn't reflect LVH. So you have a discrepancy with what looks like LVH by echo and the QRS voltage not showing it. And that, again, is the thing that you should put your antennas up and saying, wait a minute, this may not be just hypertrophy, this may be infiltration. The EF is all over the place, as I will show you in another case. Diastolic dysfunction is 100% present. Reduced GLS is 100% present with the famous apical sparring. And then increased myocardial speckle appearance, which you see here, is the least helpful criteria. Not always present, and also present with other diseases. If you want to get a beautiful picture of this, just look at somebody with end-stage renal disease. Here's another patient with a reduced EF. This patient has a small cavity, but this ejection fraction is pretty dismal. And you can see that the GLS is super low, but that apical area has much better values, and that's what you call this apical sparing. If we go back to the previous image, you might see that if you compare the movement of the base to this apex here, even without the speckle, even without the GLS, you can see already that this apex looks superb compared to all this here. So even with 2D echo, if you are careful in evaluating the different segments, you can get suspicious. It's just nice with the GLS because it shows us such a beautiful bullseye, and it kind of immediately makes you suspect amyloid. It's not 100% specific. There can be other conditions that can give you this pattern, but certainly it's very helpful to see it. And of course, amyloidosis is a disease that it's very close to our heart because we have an amyloidosis center here and take care of a lot of these patients. And you're all familiar with the three varieties, the light change, familiar, and senile. The light change is the one that is associated more with multiple myelomas. And then these other two have the advantage that in both of them, there is an increased uptake of technetium pyrophosphate when you do the examination. In this slide here, we're using the original examination that was done with planar nuclear, comparing the uptake of pyrophosphate in the heart to the adjacent lung, and showing here that patients with familiar and senile very often, over 90% of the time, have this increased uptake. Now you can actually use SPECT, so you can be even more accurate, because with SPECT you can do obviously cuts through the heart, and you can do even a better job of showing the increased uptake of pyrophosphate. So what's going on here? The LV is not dilated, maybe upper limit, but certainly it's not dilated. Okay, EF is not horrible, but it's not great. I'll let some of you do your own estimates, see what you guys think. If I were doing an estimate, I would say probably low 40s. But it's certainly not normal, okay? So it's not a big heart. Looks like a diffuse, mild hypokinesis. Yeah. What is it? This could be a left main with stoning. It could be many other type of conditions. All right, so we then go to Doppler and we see that there is a first degree AV block that might give us a little suspicion, all right? And then we look at the tricuspid regurg, and it has a velocity of almost 3.5, so this is going to put a pulmonary artery systolic pressure into the mid-50s or so. So does that make us suspicious of anything? Sarcoidosis, of course. But again, nothing here came out, telling us sarcoidosis. You have to put it together. Now, if you happen to get a little history that points in that direction, that's even better. So this is a patient with sarcoidosis. And of course, this is the classic slide of the Japanese Ministry of Health schema for diagnosing, where they basically look at the EKG, because these patients practically always have an EKG finding. They have some sort of conduction trouble. You can see the first degree AV block in that patient, but complete right bundle branch block, left axis deviations, AV blocks of different kind, ventricular arrhythmias, even VT, abnormal Q waves or STT changes. I mean, they frequently have something wrong in their EKG. And then in the echo, you look for some dysfunction of the ventricle, regional wall motion abnormalities. They may have perfusion defects, abnormal hemodynamics if they have definitely heart failure. And of course, again, you're going to hear later about CMR showing interstitial fibrosis, cellular infiltration. And that, again, doesn't come out with a label of sarcoid. It just points out to a suspicion of sarcoid. So that if you have EKG findings and at least one cardiac imaging finding, that leads you towards suspecting sarcoid, CMR can be very helpful. And then you also are going to hear later about PET scanning, because it's an inflammatory disease, and PET can also be very helpful. We all would love to be able to do a biopsy, hit it right there, and have a classic biopsy. But again, it's not always possible, because when you go in, you may not hit a good area that has the abnormality. So biopsy, although it is the gold standard, it is a tough one to always be able to get. This is a nice case we had recently with sarcoid, proven sarcoid, classic CMR and classic PET findings. And what it shows is a non-ischemic pattern of regional akinesis. So if you look here, this is not doing well. This is not doing well, okay? That could be a right coronary artery ischemia or infarction. But this is the anterior septum. That doesn't fit, right? So again, you're seeing a regional wall motion abnormality that doesn't quite hit one coronary artery, so you start wondering about something else. And this is a nice example of sarcoid. So what is this? Is this apical hypertrophy? Obviously, okay, but look at here. There is this, what looks like a possible thrombus, okay, but the EF is not that bad. Very high eosinophil count that puts you into suspecting endomyocardial fibrosis. So these are diagnoses that actually, once you have some echo findings suspicious, simple CBC can be extremely helpful because you will see this very high eosinophilic count. This was a slide given to me many years ago by Susan Weiger, very nice example of another case. There are two varieties. The infectious variety, they call it tropical because it's a parasite, most of the time schistosoma. And then the other group. And the other group is a large group that has all kinds of possible diseases involved with it. It appears to be an immunologic/allergic reaction. That's where the eosinophils come in. But it has been seen with different kinds of toxic materials, with medication allergies, with different forms of leukemia. There's even a eosinophilic leukemia. So it's kind of a basket of multiple conditions where all with one common denominator, which is the immunologic system triggering a very high level of eosinophils. So obviously the treatment for the first one is treatment of the parasite. This treatment of the second one is trying to understand better what of all these conditions is, and then there are all kinds of different modality of treatments, both anti-inflammatory as well as chemotherapy and whatnot for this condition. I don't know if they're still doing it. Bill, I don't know if you know if they're still doing it, but at one time there was a surgical option which was to go in there and scrape that thrombus from the apex out. I don't think that they're doing that anymore because they have now more medical management techniques. But I remember we had a back in the 80s. I remember having a few cases referred to Dr. DeBakey's service, and I remember Gerald Lowry doing one or two of those. I think that probably disappeared with the new modalities of treatments. All right, this is the famous Takotsubo. I'm not going to spend too much time on it because we've discussed it also. Normal coronary angiograms looks like an infarct, apical ballooning, that's the most classic. And then most patients, but not all, will recover in a week or two following the event. And as you all know, it's usually most of the time with a history of having some acute stress phenomenon. That could be a bad stress, but it could also be a good stress, like even getting married. So it's interesting that patients come. It's not just bad things that happen; it's significant life events, And this is the mid-wall variety, where you have the abnormality in the mid-wall. Again, this one recovered nicely. And this one is kind of interesting. Another mid-wall, you can see it very nicely right here and right there. And by day 7, it was partially recovered. So this one has taken a little longer to get in a path for full recovery. But now you don't see that regional change anymore. It's more of like kind of a little bit of a diffuse with an EF that may be somewhere around 40%, where here it was a lot more depressed. So they don't all behave the same way. And even though in general they have a good prognosis, there are patients that can become very sick, even cardiogenic shock. As you know, right now the common theory is that it is a massive surge of catecholamines released into the heart because triggered by some sort of stressor. There are some animal models that have been reproduced with in the animals, so that's why this continues to be the more prevalent theory. Even in one of those animal models, they use beta blockers. They treat the animal with beta blockers and they induce stress, and they did not get the syndrome. So that's why at this point in time, it's the prevalent hypothesis. I'm going to, I think this is my last group, and this is one of the most difficult cardiomyopathies to detect by echo. You really have to have a high level, and that's because the right ventricle is one of our Achilles tendon. Getting a good image of the RV is not always that possible. But so this is arrhythmogenic RV dysplasia or RV cardiomyopathy, and basically By echo, what you will be looking for is an enlarged RV, a dysfunctional RV, and even better if you can see a regional dysfunction of the RV. You may have abnormalities by EKG, as you know, this is a nice example of it with this little spike on the ST segment, but you don't always get this. This is called the epsilon wave, the little spike there. So in essence, you have somebody with unexplained RV dilation, frequently arrhythmias. They could be PVCs or whatnot. They could come in after having had a sudden death event and having been resuscitated. But what you're looking for is some type of unexplained RV dysfunction, because RV dysfunction doesn't happen by itself, usually. It's either part of a cardiomyopathy with the LV involved, or pulmonary hypertension, or severe TR. But a heart that looks okay except for the RV being dysfunctional is unexplained. You don't have an ASD, you don't have any other things. So in essence, you start with an unexplained RV dysfunction that then you need to follow through to look for more findings. And again, as you're going to hear, cardiac MRI can be quite helpful. So you exclude other causes of RV enlargement and dysfunction. LV is usually normal, but there is a rare form of the disease that also can affect the LV to make matters more complex. So in general, summary of the lecture is echo is the first test that most people are going to have after an EKG. You have to have some degree of suspicion so that when you're screening this heart, you pick up an abnormality. That abnormality you pick up is going to make you suspicious of a form of cardiomyopathy, and then you will hopefully guide the clinician into what other tests may be of help, with cardiac MRI being usually the one that we go next, although coronary angiography could be first if you have an important decision to make in terms of excluding coronary artery disease. So with that intro, we're going to have Dr. Shah tells us all about how CMR can help us today with myocarditis and dilated cardiomyopathy, and then the second session with the infiltrated diseases, accompanied also by the evaluation by PET. So are you all connected and ready to go? Yep, all right. So you can sneak in here. Get this out before I leave it.
Let's see, is this coming through? Let's try turning it off and on again. Chris, any thoughts here? Do you need to toggle to this? Click to share? Should we take the other one? Yeah, he's got his. Oh, here it is. Yep. Okay. there's HCM right there, direct. We can get accurate. Yeah, direct. Okay, so I've got 15 minutes here. I'm going to tell you guys everything there is to know about cardiac MRI and cardiomyopathies. So okay, so if you just imagine you're seeing the ACC appropriate use criteria sitting up there on the screen, you see lots of appropriate indications for cardiac MRI. And really, though, recognize it's not your first line imaging test, but it's an imaging test that you do. Yeah, you have to use your visual acuity. You'll see that it's, there we go. All right. Numerous indications, but again, used as follow-up testing after some initial evaluation, whether it be with echocardiography, with EKG or something. You don't start off with a cardiac MRI to begin with. Now, what are the tools that cardiac MRI can offer? Obviously, this I'm going to skip over very, very quickly, which is if there's ever a question about ejection fraction, regional wall motion abnormalities, LV volumes, MRI can be very useful for this. But I think really the killer application for cardiac MR is this late gadolinium enhancement. So this is a technique now which has been around for about 25 years and allows you to directly visualize the presence, location, and extent of myocardial injury. And so you can see in this example here, there's what we call like a mid-wall stripe. There's an area of hyperenhancement in the middle of the myocardium in the interventricular septum, and you're not seeing my cursor. Okay, there you go, right there. Because again, normal myocardium should appear black, and this white represents an abnormality. And we talked about in an earlier lecture the fact that in ischemic heart disease setting, the presence of myocardial injury by cardiac MRI is associated with likelihood of recovery of function. In the non-ischemic setting, I think it's probably even more powerful because it actually allows you to identify that the injury that you're seeing here is actually from a non-ischemic cause. And that can be because it doesn't fit a coronary artery distribution. So, for example, something that affects just the middle of the septum, there's no coronary artery territory that would cause that. Epicardial involvement with sparing of the subendocardium, again, that doesn't go with coronary artery distribution. Or if you have this kind of global pattern, there's no real coronary artery territory that's going to give you this. So these are clues that you have myocardial damage, but that it's due to a non-ischemic etiology. And we use this information to try to hone in on a variety of different underlying cardiomyopathic processes. And obviously there's multiple different schema for how you can break up these non-ischemic cardiomyopathies. I'm just using one example here where I'm going to break it up into the genetic, the dilated, the inflammatory, and the infiltrative or restrictive. We're going to touch on the left two today, and then we'll touch on the two on the right-hand side in a subsequent lecture. So let's talk about one form of genetic cardiomyopathy. If I show you the cine images here, I think all of us would say this is a pretty easy diagnosis, right? You've got increased wall thickness, which is primarily in the apical region. This is, again, classic example of apical hypertrophic cardiomyopathy. But again, if we apply now our delayed enhancement MRI, it gives us additional information beyond what we can just see from morphology and function, which is you can see, in fact, there's an apical infarct here. And again, this is something that occurs in the setting of apical hypertrophic cardiomyopathy due to apical trapping. And this is recognized as one of the risk factors for sudden cardiac death in hypertrophic cardiomyopathy. Here's an example of a patient with a more garden variety septal variant, where you can see there's increased wall thickness in the septum. Again, when we look at our contrast enhanced MRI, what you notice is that there's almost kind of these multiple popcorn-like areas of hyperenhancement, predominantly in the septum, which is the hypertrophied region. There's histopathologic validation, in fact, that what you're seeing here represents collagen fibrosis. And in fact, the extent of this myocardial injury or damage that we can see is associated with risk for sudden cardiac death in hypertrophic cardiomyopathy. And so now the European and the US guidelines have really suggested that if you have a scar burden of more than 15% in hypertrophic cardiomyopathy, that may represent a risk factor that in consideration for placement of an ICD. This is just another series from a different group, which again showed whether you're dealing with an obstructive or non-obstructive form of hypertrophic cardiomyopathy. The extent of LGE is associated with prognosis in these patients. And then, in the interest of time, I do want to point out one caveat, which is if you're looking for dynamic LVOT obstruction, recognize we know from the echo Doppler, this is a very short duration that this jet is peaked. And as a result, because of the lower time resolution of the phase contrast MRI, you can significantly underestimate that. Because your echo Doppler, your spectral Doppler here is about 3 millisecond time resolution. The phase contrast MRI is about 30 to 40 millisecond time resolution. So again, if you get a high velocity in the LVOT on the phase contrast MRI, that's consistent with increased velocities. But again, it's not as sensitive for identifying the true gradient. So in those cases, if there's a question of the gradient severity, I recommend going on to transthoracic echo. So hypertrophic cardiomyopathy, again, what is the role? Identification of the ventricular morphology and function. And then I think most importantly, it's identification of the presence and extent of scarring, which is associated with prognosis. This is just what the specific ACC guidelines talk about as far as the role of MRI. Let's move on to another cardiomyopathy in the interest of time, which is arrhythmogenic RV cardiomyopathy. And you can see again, there's major and minor criteria, but really it starts first with some abnormality in motion. So you have to have regional RV akinesis, dyskinesis, or dysynchronous contraction. And then once you have that, then you look for evidence of RV dilatation or RV dysfunction. The specific numerical criteria are shown here, which again, if anybody's interested, you can pull these up and read these. But again, recognize you've got to have Walmart abnormality first, and then you look for dilatation or dysfunction of the right ventricle that meets a certain threshold. And then we also now have learned that in addition to the classic RV cardiomyopathy, there's also an arrhythmogenic LV cardiomyopathy as well, and it can also affect portions of the left ventricle. Here's an example of a case of left-dominant arrhythmogenic cardiomyopathy, where it's often been described that the LGE pattern that you see is almost a ring-like pattern of hyperenhancement. Here's a patient who has extensive hypertrabeculations, as you can see here. If we were to look at volumetric criteria, this is a dilated ventricle with a depressed ejection fraction less than 30%. And we could go through and actually measure the amount of the hypertrabeculated as well as the compacted myocardium. And one of the criteria that's used on MRI is a diastolic ratio of more than 2.3 to 1 of the non-compacted to compacted, as suggestive of LV non-compaction. There's another set of criteria called the Jacquier criteria, which instead of looking at just one single segment, looks at the global volume of non-compacted myocardium and compares that to the volume of compacted myocardium. And in this criteria, a threshold of more than 20% non-compacted myocardium meets the Jacquier criteria for LV non-compaction. And then other important things to keep in mind with non-compaction, because of all of these hypertrabeculations, you can have blood trapping, and as a result, these patients can be at risk for developing LV thrombus. And again, using our delayed enhancement technique, we can modify the settings a little bit to make it more of a thrombus probe, and you can see if there is thrombus, you'll see an area of black or signal void. Important to keep in mind, LV non-compaction is likely a spectrum. There's a number of things that can do that. Some things which are, can occur in athletes, can occur due to other secondary conditions. So again, it's important to recognize LV compaction may in fact be not one single entity, but a spectrum of a variety of different etiologies. And I think most important is there's now several studies that have shown that the extent of the trabeculations are not what predicts prognosis in these patients, rather it's LV function. It's the LV ejection fraction is what's associated with prognosis in these patients. Let's move next to dilated cardiomyopathy, and I'll wrap this up here in the next few minutes. Here's a patient who comes in. You all know the classic criteria for Takotsubos, which are shown here. And if I show you this example patient, you can see there's a large wall motion abnormality all along the mid and apical segments. And this was a multi-center series that looked at a cohort of almost 250 patients that presented with suspected Takotsubos. And what you'll notice is that most of them, over 80%, had that classic pattern where the mid and apical segments were the ones that were abnormal. But about 1 in 5 had what was coined a mid-ventricular ballooning pattern, where the apex contracts normally and the base contracts normally, but it's really the mid segments that are dysfunctional. And then a rare 1% actually had an inverted pattern where the basal and mid segments, the basal segment is the one that's abnormal, and the mid and apical segments actually are contracting normally. And about 1 in 3 had RV involvement. So they coined the term biventricular ballooning pattern. Now, important in these patients with Takotsubos, there's really not a lot of myocardial injury that occurs. We can see that as manifested by low elevations in troponins. And when we do our delayed enhancement MRI, you're not going to really see any extensive area of hyperenhancement in these patients. And so again, in a patient that you're concerned about Takotsubos with a classic wall motion abnormality, if on the other hand, when you do your delayed enhancement, you see the whole apex light up with hyperenhancement, that would be suggested that maybe this is actually an LED infarct and not Takotsubos. And then obviously what we know is that for patients with Takotsubos, the prognosis for these patients is fairly good. And in this series on follow-up imaging, the LV ejection fraction improved substantially and normalized. And there was also reverse LV remodeling with a reduction in size of the left ventricular end diastolic volume. Now let's look at one more case here. This is a 44-year-old gentleman who comes to the hospital on a Friday evening with chest pain. He has tobacco abuse history, has a history of premature coronary disease in his family. His initial EKG shows just some nonspecific ST segment changes, but he has a significant elevation in his troponin and his CKMB. He's treated over the weekend with IV heparin and antiplatelet therapy, goes for a cath on Monday, and you'll notice, I don't know how well it projects with the lights on, but the LED looks clear. There's no obstructive lesions in the RCA or in the circumflex. So this person is thought to have evidence of myocardial infarction or myocardial injury, but has non-obstructive coronary artery disease. So this is now a classic case of the Minoko spectrum. And where cardiac MRI is useful here is to try to figure out, well, what is the cause of that cardiac enzyme elevation? Did this person, in fact, have a myocardial infarction from a coronary etiology that the vessel is just recanalized at the time we take him to the cath lab? Or has he had something else? So this person then came to the cardiac MRI lab. And if you look especially at the images on the bottom here, what do you notice? You notice kind of multiple patchy foci of enhancement in the lateral wall. And this, again, would be a classic abnormality that you would see in the setting of myocarditis, because, again, coronary artery disease wouldn't give you those multiple patchy foci. This was a series almost 20 years ago now from Germany, where they looked at a series of patients that presented with suspected myocarditis. What was unique here was that after they underwent the cardiac MRI, they were taken to the cath lab and underwent endomyocardial biopsy at the site where hyperenhancement was evident on the MRI scan. You can see the different patterns of hyperenhancement that you can see. Again, all non-ischemic patterns of hyperenhancement. And interestingly, what they found, again, a small series, but series where they had biopsy at the site of hyperenhancement in all of these cases, is that in 90% of these cases, they actually were able to find evidence of virus, herpes virus or parvovirus. And only 10% of the time the biopsy was negative. So I think from a diagnostic standpoint, if you have a concern about myocarditis or you have a concern about elevated cardiac enzymes of uncertain etiology, this is where cardiac MRI can be very useful. And from a diagnostic standpoint, you're looking for two things. You're looking for T1 weighted criteria, which can either be usually from LGE or other techniques that allow you to identify T1 abnormalities, along with T2 weighted abnormalities, which suggest that this abnormality that you're seeing is actually acute. And then other supportive findings for myocarditis would be the presence of systolic dysfunction, presence of a pericardial effusion, or pericarditis. And then I think also importantly in myocarditis patients, there's now multiple series that have shown not only is MRI useful from a diagnostic standpoint, but also from a prognostic standpoint as well. This is a series of patients that presented with suspected myocarditis. If they had evidence of LGE, the prognosis in these patients was much worse compared to those patients who came with suspected myocarditis but had no evidence of LGE on cardiac MRI scanning. And then I'll lastly finish off with the idiopathic dilated cardiomyopathy, where again, in these patients, sometimes you'll see evidence of hyperenhancement or LGE, but it tends to be, or it is in a non-ischemic pattern. Oftentimes it tends to occur in the middle of the septum. And again, it's called this kind of classic mid-wall stripe. This pattern is also associated with a worse prognosis in patients with non-ischemic cardiomyopathy. This was an initial series from a group in UK, which was single center, which showed worse all-cause mortality as well as worse sudden cardiac death. And then this was a multi-center series that we were involved in that showed, in fact, that prognosis in these patients with non-ischemic cardiomyopathy is affected both by LV ejection fraction as well as by the presence of scar detected by MRI, and that all-cause death and cardiac death was affected by both. But interestingly, if you look at sudden cardiac death or arrhythmic events, they were primarily associated with scar presence, not with LV ejection fraction. So, and then I think one of the strengths here is that whereas ejection fraction is a dynamic measure, it can change from time to time with medical therapy, with just a natural history of the disease process. Scar is a very stable substrate in the sense that if you repeat image a patient, the scar is not going to go away. The scar may progress in a small percentage of patients, but it certainly doesn't regress. And then so to wrap up, what we touched on today was where cardiac MRI could be useful in certain genetic or dilated cardiomyopathies. Next time, we'll talk about the inflammatory and the infiltrative restrictive cardiomyopathies, the role of both CMR as well as nuclear-based techniques. And so to kind of wrap up here, I think really the key strength of MRI is its ability to directly visualize myocardial fibrosis. And this aids both from the standpoint of improving your diagnostic abilities, but also from the standpoint of providing prognostic implications as well. Thank you for your attention. Okay, we've got, if there's one quick question, Dr. Kuna would come on up. We'd be glad to take a quick question or two. And if not, that's perfectly fine too. All right. Thank you all for your attention then. Yep.